Ladies and gentlemen, thank you for joining the Lake Superior Quality Innovation Network and Integrated Behavioral Health Concepts. Your host, Mark Lash, will begin.
Thank you so much, Katina. Hey, good afternoon, everyone. Thanks for being with me this afternoon. We're going to talk today about some integrated behavioral health concepts. And so my name is Mark Lausch, and I will be your presenter today. So we'll begin with some housekeeping announcements. You can post any questions using the chat function, but please address your questions to the entire group so all of us can read your inquiries or your comments. There will be a question and answer period at the end of the presentation if time permits. Michigan social workers, you will be able to receive 1 credit hour of approved CE. That's through our partnership with St. John Providence Health System, and we thank them for sponsoring the social work CEs for this event. What you'll need to do is watch the entire webinar, and at the end there will be a link that you'll be able to access, and you will go there. And some of you probably have been with us before. If you haven't, you'll need to register using a name and a password, and it will take you to the evaluation. And you'll be able to take the evaluation. I'll give you the access code at the end, and you'll be able to print your certificate. You'll also need your social worker license number to access the evaluation. So I'll let you know that now if you want to pull that out or find it in your phone or wallet. Okay, and for all the other attendees other than Michigan social workers, the evaluation will display on the screen at the end, and we hope you take the time to do that for us. It helps us get feedback and understand how we can do better. So our objectives for today, we're going to understand the basic definitions of integrated care, understand the prevalence of behavioral health conditions in primary care, hope you'll be able to identify the various models of integrated care and their strengths, and then understand that behavioral health screening is a positive first step in integrating care for patients, integrating behavioral health care for patients. Okay, before we begin, I just want to take a minute to introduce you to the Lake Superior Quality Innovation Network, or LSQIN. Some of you will be familiar with this material already, others won't. In August of 2014, Michigan partnered with Minnesota and Wisconsin to form the Lake Superior Quality Innovation Network, or Lake Superior QUIN. Through our partnership, we can create efficiencies and avoid duplication of efforts while continuing to provide quality improvement boots on the ground work with our partners and stakeholders in each state. So as you can see, a number of beneficiaries. These are Medicare fee-for-service beneficiaries. So we have over 3 million, 5 across the 3 states. And our partners are named Stratus and Metastar. Okay, and as part of our partnership, we are working toward the CMS, or Health and Human Services AAA, better health care, better health, better care at lower costs. And these are just some of the areas in which MPRO and Stratus and Metastar, the LSQN, work in. So you take a gander at that. Okay, let's get down to the meat and potatoes of this, starting by talking about making the case for integrated care with some definitions. So let's begin with that. So we'll start with primary care. That's the place where most patients, or the definition of that is where most patients receive most of their care, and it is usually the first source for any treatment, medical and behavioral health. Behavioral health care can be provided, or BH, can be provided in the primary care office setting or by specialty mental health providers. And these include psychiatrists, outpatient therapists, they may be social workers, Master of Arts in Psychology, PhDs, or licensed professional counselors. And behavioral health care includes both mental health and substance use disorders treatment. And primary care includes family medicine, general internal medicine, pediatrics, and sometimes OB-GYN. Specialty mental health, MH, and substance use disorders, SUD. And I'm going to use the definition in the DSM-5 of substance use disorders. These include inpatient, outpatient, intensive outpatient, day treatment, and community mental health services. These can be freestanding or unit-based for inpatient programs, and can be private or public mental health settings. Okay, so what's integrated care? People with mental and substance use disorders may die decades earlier than the average person, mostly from untreated and preventable chronic illnesses like hypertension, diabetes, obesity, and cardiovascular disease that are aggravated by poor health habits, such as inadequate physical activity, poor nutrition, smoking, and substance use disorders. Barriers to primary care, coupled with challenges in navigating complex healthcare systems, have been a major obstacle to care. At the same time, primary care settings have become the gateway to the behavioral health system, and primary care providers need support and resources to screen and treat individuals with behavioral health as well as general health care needs. Some of the common abbreviations used in integrated care are on the slide here, and these include IPC, or Integrated Primary Care, IBH, Integrated Behavioral Health, Community Mental Health, or CMH, and BHP would be a behavioral health provider. So integrated care and integrated primary care will be used interchangeably during the presentation. And we will be discussing how primary care physicians can blend behavioral health care into their practices. Okay, integrated primary care varies from population to location to setting. Some CMHs are partnering with FQHCs to provide services to their populations and are in the process of reverse integrating, and that is working toward providing needed medical services to populations of those with chronic mental illnesses and substance use disorders who have traditionally not sought medical services or who have been not been consistent with medical follow-up for their chronic conditions. Macomb and Wayne CMH are currently doing this. They're teaching and instructing their clinicians on medical conditions and basic skills to recognize chronic health conditions and to manage physical health. So that's a very positive thing. Okay, we're going to talk a little bit now about prevalence. So these figures illustrate the need for behavioral health integration and identification of behavioral health conditions in primary care. As we can see on the slide, that 20 to 25% of patients in primary care present with mood and anxiety disorders. And this percentage can be up to 50% in the underserved and those with chronic disease states. Primary care physicians typically under-identify behavioral health problems in their patients. And that's not for lack of wanting to. And behavioral health problems often go unrecognized by the primary care physician. Screening rates actually in Michigan, screening for alcohol and alcohol use disorder and depression are generally less than 1%. And that doesn't mean that it's not being done. It sometimes means it's not being billed for. But in a lot of cases, it's not being done, or it's not being done in a systematic way with validated tools. So physicians screen fewer than half of their patients for alcohol use disorders, and about 2/3 with a behavioral health disorder do not get treatment. Depression identified in fewer than 50% of primary care patients. And oftentimes when treated, the outcomes can be suboptimal due to inadequate monitoring and follow-up. So those who do not get treatment, this happens for a number of reasons, including patient resistance and denial, lack of resources known by the primary care physician, lack of resources in the community, lack of identification of the behavioral health disorder, unavailability of mental health services in the area in which the primary care doc is practicing, and this is especially true in outstate areas, in rural areas, or semi-rural areas in Michigan. We were talking to one primary care practice in the mid part of the state, and one of the practitioners, one of the providers was telling us that he essentially had, I think, like one psychiatrist in the entire county to refer patients to, and that person wasn't taking referrals. And the lack of specialty mental health or outpatient behavioral health clinics was very lacking in that area too. So they sometimes their primary care providers are sometimes stymied in their abilities to provide integrated behavioral health care. Suboptimal outcomes are caused by a lack of understanding about behavioral health disorders, fear of treating patients with behavioral health disorders, lack of knowledge about resources to assist in treating behavioral health patients, lack of monitoring by the primary care doc due to lack of understanding of psychotropic meds and because of patient disease burden. Okay, behavioral health conditions that are not effectively treated can lead to significant consequences, including what you see on the screen. I'm sure many of you have worked with or heard stories about patients with co-occurring medical and behavioral issues that exhibit all or some of the symptoms noted here. And these are well documented by CMS, by health plans, some of whom are on the call today, anecdotal stories, and practice experience. So, persons with diabetes, hypertension, and other chronic conditions are frequently depressed and may use alcohol and other licit or illicit substances to cope with their disease burden, stress, and family situations. Becoming comfortable and proficient with behavioral health screening, interpretation of results, brief advice, and referral options can improve overall efficiency and ability to manage these complex patients. Relationships with behavioral health providers and specialty mental health providers also can allow for sharing of some of the burden of those with complex behavioral medical conditions, and that way the practitioner, the primary care physician, doesn't have to feel so alone, and isolated. Okay, so what's in it for me? Benefits of integrated care can range from improved quality of care, improved patient outcomes, and better overall satisfaction. There's also reimbursement available for screening and brief counseling services, and we'll talk about that in just a minute. And it's been our experience that when CMS funds initiatives like what we're doing now in the QINs with our behavioral health project, which I'll go into a little detail at the end of the presentation, that when CMS funds these kinds of initiatives, they're looking at screening in primary care. That typically means that some of these services may be mandated later on. So the integration of behavioral health care is pretty much here to stay, and I'm sure that I'm not, that I'm preaching to the choir in the audience here that I'm speaking to. I'm sure you wouldn't be on this call if you didn't believe that integrated behavioral health care is really where we're moving. And it would be beneficial to make small strides now in anticipation of future requirements and or penalties. So some of the benefits include, obviously I just said improvements in quality of care and patient satisfaction, taking advantage of reimbursement, being prepared for the future, and also if you wanted patient-centered medical home NCQA recognition, integration of behavioral health could assist you with that. And so again, just a little bit more on the patient-centered medical home requirements. Include standards to address behavioral health. Some of the PCMH components include patient-centered access, team-based care, population health management, care management and support, care coordination and care transitions, and performance management and quality. And by looking at some of the standards to address behavioral health issues, depression, substance use disorder, and obesity is in there too, you can enhance access and continuity by screening using PHQ-9, CAGE, or audit. You can plan and manage care. One of the conditions needs to be mental health and substance use disorder. Provide self-care and community resources, track and coordinate care, and measure and improve performance. And all these things can be done in treating the behavioral health issue in the primary care setting, all the while moving, if you would like to move toward PCMH designation. So we're going to start now talking about integrated care in action and some examples of integrated care models. So in the past, primary care and behavioral health services were separate entities and most often separate silos. And I wanted to keep the slide here pretty minimal. I guess I could have come with a really a nice picture of a farm barn silo, but I just used the three here to indicate that. And as you all know on the call here, that a lot of services continue to be siloed, but we are moving in a better direction. With the siloed approach, there was a general attitude of exclusion and reluctance to work or collaborate with others. With the interest in integrated care coordination, and care transitions, we have seen positive movement in healthcare systems, acute care systems, home health agencies, skilled nursing facilities, community mental health, specialty mental health providers, and others working together to provide more collaborative and to work cooperatively to increase coordination of care, improve patient outcomes, and reduce costs and redundancies. As more and more systems are moving from silos to more coordinated and collaborative models of integration and cooperation, we can see behavioral health becoming more integrated in medical settings. We want to see the paradigm shift from working within to as a part of, and I think that's what I think all of us would like to see it get to. And as we see on the slide here, the continuum can be viewed as the movement from an external consultant to an integrated partner, and again, working with primary care as opposed to within and as a part of primary care. I think that's obviously the goal that we want to move toward. Examples of integrated care in action. So we have three separate models: coordinated, co-located, and integrated. I'm going to talk a little bit about each one and provide some examples of what they may look like and how they may operate. Okay, we're going to start with the coordinated model. In this model, there may be some communication between the primary care provider and the social worker or behavioral health practitioner, but more often than not, there is probably only minimal acknowledgement of progress in therapy or coordination of medical care by the social worker or behavioral health provider. The behavioral health provider may send progress reports to a primary care doc, but these may or may not be integrated into the care plan for, say, diabetes or hypertension, and may not be shared or read by the multidisciplinary team at the primary care office. In this model, there is little understanding of the culture of the other. Now, when I came into the field in 1989, this is the model that was prevalent when I first started doing social work practice. It was very rare that when I had a patient that I saw for an assessment or an intake or for ongoing therapy, I would communicate with his primary care doc. I might get a release for that because it was standard policy and procedure because of accrediting bodies, CARF, Joint Commission. But very little was done with that release of information unless there was a specific need to communicate with the primary care doc. And the mentality was, and I know I had this too, is like, well, why does the doctor care if you're in therapy? Or they don't care. You know, I mean, I guess I could see that they would care, but my perception of it and my colleague was pretty much, well, they don't really need to know any of this stuff. So I think that the movement from having an ignorance or a lack of understanding of the need for this behavioral physical coordination, moving now to more understanding and recognition of this. So an example of this would be a patient being treated by a primary care doctor for diabetes while seeing a social worker for anxiety and depression, and there would be little communication between the two providers at all. The co-location model, one, is where the behavioral health provider shares space, but essentially a separate service. So that might mean where I know one of the primary care practices we're working with was looking at bringing a mental health provider from a specialty mental health provider into the office 2 or 3 days a week to consult with the doc, to see patients, and things like that. So they were moving into this co-location model. So there is increased contact between providers. It does decrease the stigma of making referrals for behavioral health services because you see the social worker or the mental health provider on site, on location. You get to meet them, you get to know them, they get to know you, and there is some interaction there. So behavioral clinicians could be stationed in primary care offices to provide consultation, substance use disorder, mental health assessment, sometimes psychotherapy or cognitive behavioral therapy. But generally, most cases, the way it starts with this co-location model is that it's really there for consultation and assessment and maybe brief advice as opposed to psychotherapy. The behavioral clinician maintains separate billing and scheduling, but could be available for emergent situations. And it's a good place to start. The co-location model 2. This model has been utilized in hospital EDs to provide assessment, referral, and behavioral management services. Payment for behavioral health clinicians is usually shared with the hospital and behavioral health provider. In primary care practice, this is more difficult as outpatient behavioral health providers typically pay for staff on a contractual basis. So clinicians only make money if they see patients and can bill for those services. So screening, consultation, et cetera, are usually sometimes not reimbursable for the behavioral health clinician. So if the clinician is salaried with shared costs or through grant funding, this model can work well and allow the behavioral clinician to fulfill more functional roles in the primary care office. And this includes some close collaboration with some system integration. Possibly could have joint records, but more likely read-only access to the medical records, and then for the primary care staff, the behavioral health records that the behavioral health clinician keeps. There may be joint conferences, consultations to discuss patients, review processes, things like that. And in this model, you're seeing a movement towards seeing patients as shared patients and not as separate entities for either of the providers. Some of the barriers, again, I mentioned reimbursement may not be available. Time for conferences is hard to find. Billing systems are oftentimes different, and there may be limited or no access to records. We're moving now into the integrated model. So we have an integrated model 1, and this features closer collaboration, moving to full integration, development of joint treatment plans, work on complex patients as a team. So if there's a patient that presents with significantly complex issues, medical and behavioral, that the team works together on that and sees, and there is a joint treatment plan for the progress of the patient. This one is not fully integrated as the behavioral clinician is still working within the primary care system. There may be shared electronic health records, and billing may remain separate. But this does feature increased understanding of the other's culture and role and frequent in-person communication. And that's absolutely crucial, is understanding the culture of primary care. A lot of behavioral clinicians, myself included, are not very familiar with the culture of primary care. I go see my primary care doc, and I know she's busy, yes, and I know she carries a little computer around with her, but I know very little about the culture of primary care, which is part of why we have at Empire here, we have a multidisciplinary team working on our behavioral project, those which have a better understanding of the primary care culture, and then myself and some of my colleagues who fully understand the behavioral health culture. And then we move to the integrated model 2. And this is a fully integrated model with unified primary care and behavioral health. Behavioral health is a routine part of the medical care that's provided to the patients. The behavioral clinician is a part of the primary care team with the primary care doc as the team leader. There are warm handoffs for behavioral health, and some of the other models too offer warm handoffs. When you've got a co-located or embedded behavioral clinician, you're certainly giving warm handoffs, or a lot of the time you're giving warm handoffs. And this model adopts a short-term model for treating ongoing behavioral conditions. Treating mild to moderate in the practice, referring long-term or complex issues to specialty mental health or substance use disorder treatment. There is an in-depth understanding of roles and culture. And one of the examples I want to provide for this is Dr. Corey Waller's Center for Integrative Medicine. Dr. Waller works for Spectrum Health, and he's got a pretty varied background. And he runs the Center for Integrative Medicine in Grand Rapids, and that's a clinic that provides full-service medical and behavioral health services to patients who have been identified as high utilizers. And that includes 10 or more visits to the ED in the past 2 to 3 years. Now, his is a shorter-term model because what the ultimate goal for Dr. Waller's Center for Integrative Medicine is to return the patient back to a primary care provider in 18 to maybe 24 months. So rarely are patients discharged or transferred out for quote-unquote behaviors, resistance, hostility. Again, if a patient is violent or I'm sure there are reasons why patients do get transferred out of the Center for Integrative Medicine, but it's very rare. The use of specialty mental health and substance use disorder treatment is needed. It's an incredibly successful model when staffed correctly, and the Center for Integrative Medicine is. And he has proper support of the culture and support of the health system and the hospital system for him to do this. So that again, the Center for Integrative Medicine is kind of a short-term. It's kind of short-term to a long-term, 18 months to 24 months. That's 2.5 to 3 years, 1.5 to 2 years. And then the patient is ready to return to primary care. So they stabilize the patient, address their medical and behavioral needs. Their staff, they're especially trained from the receptionist all the way down to the physician and or residents treating the patient on this culture of the behavioral health culture, primary care culture. So it's truly a fully integrated model. Strengths of the fully integrated model: increased efficacy, communication barriers are removed, better continuity of care, absolutely, better access to care. And some other examples of where this model is currently being utilized would be the VA Centers for Integrated Healthcare, Outpatient VA, Integrated Primary Care, and Department of Defense Military Health System. And again, these are systems that have significant funding from a significant funding source, and are able to do this. Some other examples in Genesee County, Genesis Regional Medical Center, Grand Blanc. They have family medicine and internal medicine residencies that put a focus on behavioral health care, the Hurley Medical Center Pediatrics. There's some integrated care going on there. MyPIC, the Michigan Primary Care Transformation Project, which was a CMS-funded 7-state demo project, and it was focused on the development of a patient-centered medical home model. And they recently got a 3-year extension to address social determinants and behavioral health integration into primary care. So they're currently working now to develop assessments for social determinants and working at behavioral health care integration. They are working with approximately 350 practices in Michigan, some of whom are working on the MPRO Behavioral Health Project or the LSQIN Behavioral Health Project. And we have partnered with MyPIC to promote integration and best practices. So utilizing social workers to assist primary care practices with identification and management and referral of patients with social determinants is what they're doing. So they're looking at the social determinants being poverty, housing issues, family issues, transportation, and behavioral health. And some of their focus areas include case management, self-management support, care coordination, and linkages to community services. Community mental health authorities. Performing both integration and reverse integration. They're educating their behavioral health clinicians on medical conditions, potential drug interactions with psychotropic meds, and meds used to treat chronic diseases, signs and symptoms associated with major chronic diseases. So their clinicians are better able to identify physical health conditions along with their expertise in behavioral health. And they have integration of behavioral clinicians in primary care clinics and co-location models in primary care and the ED. Acute care hospital systems are working toward integrating care, co-location of behavioral staff in ED, and one of our partners, Molina, has had a very successful, or still working on, a very successful collaboration with some emergency departments in Genesee County to identify behavioral health patients that show in the emergency department. And so when a Molina patient shows up in an ED in Genesee County, a care manager, or they have a contract with like a crisis interventionist that will go to the ED and develop plans for that patient to divert from a hospital admission or a psychiatric admission. And actually, Dr. Briles will be speaking about this a little bit more in detail at one of our upcoming meetings. And it's a very successful program. St. John Providence has been utilizing social workers to provide behavioral health services on acute care floors. They received some grant funding to demonstrate the efficacy of enhanced behavioral health-focused discharge planning. And Stephanie Grady is one of our longtime partners here who came up with that idea. And they recently got funding for some social workers, and they're training them to do enhanced discharge planning with patients with chronic medical conditions discharging. Adult Wellbeing Services recently received funding from SAMHSA to develop an integrated care clinic at their Detroit location. So this model is another reverse integration model in that they will be embedding healthcare providers, including an RN, a registered dietitian, case managers, and a medical doctor in their traditional mental health substance use disorder clinic. And they'll begin accepting patients in March, and their grant runs for 4 years. In Wisconsin, one of our partners in the LSQIN, they are working with FQHCs, federally qualified health centers, in a project called Access Health, which is the development of an integrated primary care consulting toolkit, and it is utilized to assist primary care physician delivery of integrated care. They've also been doing a lot in Wisconsin on the SBIRT model. SBIRT is screening, brief intervention, and referral to treatment model. And it is a model that is promoted for use in primary care, where the basic concept again, screening, the primary care doc would do some brief intervention, and if needed, a referral to treatment. So the SBIRT model calls for community-based screening for health risk behaviors. It offers an opportunity to identify problem drinking and substance use, and it can trigger interventions. So SBIRT has been shown to improve outcomes for patients who are screened and either counseled or referred for substance use disorder treatment. So the SBIRT model is focused on alcohol, primarily alcohol, but it can be modified to include drug use also. Okay, so we've talked a little bit about the prevalence. We've talked about making the case for integrated care. We looked at some co-location models and some integrated models. We've looked at or talked a little bit about some of our partners and some folks doing some of this work in both Michigan and Wisconsin. So, as a primary care physician or someone who works for a primary care doc, where do I begin? So, make the case for screening. So, behavioral health screening is an early intervention that can prevent some avoidable conditions from becoming worse and prevent or delay complications. So, screening is the right thing to do for patients. Integrating processes for performing behavioral screening will reap benefits, and we had one of our previous presenters at a behavioral health event a couple years ago, Dr. Boudelaire from Kaiser Permanente. He said something that made me think, and he talked about using alcohol as another vital sign, or alcohol use as another vital sign, or mood and alcohol as another vital sign. So when you see patients in practice, that not only do we take their blood pressure, pulse, and things like that, but that we also do possibly a PHQ-2, PHQ-9, or an audit or a cage to see where they are with if there's any prevailing alcohol or mood issues. In addition, the U.S. Preventive Task Force recommends depression and alcohol screening yearly for all patients over 18, including pregnant and postpartum women, and that recommendation just came out a couple weeks ago. And behavioral screening is associated with improved outcomes for patients. It is also one of the first steps toward integration, and it's reimbursable from Medicare, fee-for-service Medicare, and most other third-party payers. Okay, so we're going to look at, this is just a minor grid that looks at the type of screening procedures that are available. what the reimbursement rate is and some notes on that. As we can see that for the alcohol screening has a HCPCS code, a G code. The reimbursement rate is at $17.36. There's depression screening. The initial preventative physical exam also has a part in it for, there's a component for depression screening and also a component for health risk behaviors that could include a substance use disorder screen. And then a primary care doctor also available, or can also bill to do brief counseling for alcohol use disorders at a rate of about $25.14 for that particular service. And the reason I put this up there, those of you that will be working with us on the Behavioral Health Project, we will certainly provide more in-depth guidance on billing and coding and reimbursement for alcohol and depression screening as we move forward with you over the next 4 years or so. So I just put this up there just to show that there is reimbursement available for screening. Types of screening tools. Verified screening tools. So for depression, the kind of the gold standard would be the PHQ-2, which is 2 questions, which can be added to an EHR as an initial screen. There is also the PHQ-9, and it's called the Patient Health Questionnaire. 9 questions used when answering yes to any of the 2 questions in the PHQ-2. There are other mood and anxiety screening tools such as the GAD, or Generalized Anxiety Disorder 7, the Hamilton anxiety screening tool. That's for anxiety. SAMHSA is for the mood, alcohol, and substances, and the GDS or geriatric depression screen. Most people in primary care are going to use the PHQ-2, PHQ-9. There's also the back depression inventory that's available too, and that's a decent tool also. But most people are going to use probably the PHQ-2 and 9. The reason being, PHQ-2 has 2 simple questions. As you read on the screen. So a yes to either question suggests the need for further evaluation by most people would then use the PHQ-9 for that. And so if the patient screens negatively or says no to either of those questions, the screening is over and it's done, and then you would repeat that at the next visit or in another year, depending on how you're treating patients as they come and see you. So most practices, again, begin with the PHQ-2 as the initial depression screening tool, and then move on to the 9 if either of those questions are answered yes. Now, I didn't put the 9 on there because there's 9 questions, and it's easily downloadable, and most of you probably have seen it, so I didn't include the PHQ-2 9 on there. Okay, alcohol and substance use screening tools. There's the CAGE. And CAGE Aid. CAGE is for alcohol. CAGE Aid is for drugs and alcohol. The CAGE is 4 questions, easily administered and memorized. But this is not recommended for facilities accredited by the Joint Commission because the Joint Commission came out. Some of their guidance indicates that the CAGE and research does show this, that the CAGE is more designed to show more problem drinkers. As opposed to the audit or the audit C, which is better equipped to tease out those with more moderate drinking problems. But the CAGE is an easy tool to remember. The CAGE stands for have you ever attempted to cut down? Has anyone ever been annoyed by your drinking? Do you ever feel guilty about using alcohol? And have you ever used alcohol in the morning or as a remedy to a hangover? So they're very easy. It's mnemonically easy to remember the 4 CAGE questions. But again, those of you that are looking or affiliated with health systems that are Joint Commission accredited, it might be better to consider using the audit, which is a 10-question alcohol use disorders inventory test. I think my memory serves me correctly, and the Audit C, which is a 3-question shortened version. The MAST is the Michigan Alcoholism Screening Test. That's 22 questions. There's a short version available, and the DAT is the MAST, but it focuses on licit and illicit drugs. All of them, all of these on the screen here are validated screening tools. I put CMS verified screening tools, and that's for the purposes of those folks that are working with us on the Behavioral Health Project, and that's one of the requirements of the project that primary care practices use a verified screening tool. So probably in most cases the audit is or CAGE, depending on where you want to go, is the best way to do that. Now with the audit, you will actually screen, more people will screen positive for the audit because it is geared to tease out less problematic drinkers. The CAGE will probably, you won't screen as many people positive with the CAGE, and like I said in the last, just a minute ago, that the CAGE is, the CAGE is designed, or it's not designed, but it tends to identify more problematic drinking behaviors and not less progressive. Okay, whoops, we missed that slide there. So there we go. Oh, I have a snappy little thing here. Lake Superior QIN Behavioral Health Project. I'm going to spend just a minute or two talking about that, and then we will wrap up this afternoon session. And the Lake Superior QIN Behavioral Health Project is a 5-year, well actually 4 years now. It will end in July of 2019, and we are focused on assisting 200 primary care practices to implement processes for alcohol use disorder and depression screening. What we're trying to do is get them to improve their process if they're doing screening already for either depression or alcohol. And a lot of practices are using the PHQ-2 and or PHQ-9. So it would be to look at those processes, and if they're doing some of the screening, assist them in picking up the alcohol part or the substance use disorder screening part, and then help them find processes and workflows to bill for those services. So if they're doing them, they can seek reimbursement for that. The next screen will tell you about that. We're working with 200 practices, improvement of screening rates, and through that, too, what we also want to do is we want to help the primary care practices improve coordination of care. So what we want to do is develop referral networks for those recruited primary care practices. We want to help them develop referral networks. We want to be able to help them with warm handoffs whenever possible to behavioral health providers if there is a need for referral. So if they're screening, some of those patients, depending on the severity of the screen, they might be able to be treated in the primary care practice for depression, maybe with low dose SSRIs or SNRIs or SSNRIs. And they could be monitored in the practice. Some patients, they require referral to primary mental health and specialty mental health. So, we can help them develop referral networks where they feel more confident and comfortable in making referrals out for services that are needed. And we want to provide technical assistance to our practices to help them do this. The second part of the Behavioral Health Project is working with inpatient psychiatric facilities. And we are going to be working with 5 IPFs, that's the CMS term for inpatient psychiatric facilities. We're going to be working with 5 IPFs in Southeast Michigan, and we're currently working on with them, and we've just begun working with them to help improve the 7 and 30-day follow-up for recently discharged IPF patients. Okay, reduce 30-day all-cause readmissions to acute care and IPF settings, and provide technical assistance to meet these outcomes. The reduction in 30-day all-cause readmissions to acute care and IPF It is hoped that by improving 7 and 30-day follow-up and in working with patients, developing processes and systems to track and monitor patient follow-up, that would have an impact on reducing 30-day all-cause readmissions back to the psych facility or into an acute care setting. And I guess this goal too, where this kind of goes in conjunction with some of our care transitions work that we're currently doing in Southeast Michigan and across the state of Michigan. And actually, just a reminder that Minnesota and Wisconsin are also working on the exact same goals that I just mentioned. They too are working with 200 primary care practices and 5 inpatient psychiatric facilities in their respective states. So what we do is we kind of get together to develop technical assistance approaches. We sit down and figure out some of the best practices, where we can be of assistance, how we can be of assistance, but the actual boots on the ground work with the facilities is done by the respective states. So as part of the behavioral health project, those of you that are recruited into that or would like to be, learning sessions, we offer those, such as what I'm doing today, webinars, in-person events, lunch and learns. We do have a behavioral health listserv that we initiated back in 2013 as part of a one-year funded program from CMS, a special innovation project on behavioral health that some of you were involved in. And the listserv is a real-time resource tool, a communication tool that helps build relationships, that fosters the development of real-time resources and the spread of best practices. We have regular behavioral health collaborative meetings that focus on networking, relationship building, best practice dissemination, and learning from our partners what they're doing in the area of integration of behavioral health care. And we also provide technical assistance to recruited providers and primary care practices. Okay, just one final thought here on the power of community. As we move closer to the close of this presentation, I just wanted to take a few minutes to discuss care transitions and the power of community. As we can see in the slide, the patient is at the center of a continuum of care that begins and ends with them. This slide doesn't include behavioral health providers, but they're there in the spokes of the wheel there. We can visualize them, in the spokes of the wheel, just as we can see the, physician offices and hospitals, pharmacies, emergency medical services, palliative care, home health care. The Lake Superior Quality Innovation Network has established care transitions communities that are actively working to reduce avoidable readmissions and improve communications between settings of care. These communities meet on a regular basis to review data, decide on interventions that can be integrated into their care settings. Examples of these interventions may include medication reconciliation strategies, discharge instruction checklists, coaching models to follow discharged patients to assist in achieving follow-up recommendations, checklists that can be used in acute care settings to improve safety, and other techniques to improve coordination of care. It's important, as we talk about integrating care, that we look at resources beyond physician office and acute care providers. No one setting of care can address all the patient needs, and patients spend the majority of time at home and in a community setting. Thus, care coordination is an effective means to improve patient care, not only for patients with behavioral health needs, but all patients. Readmission penalties and other healthcare legislation have brought care transitions into the spotlight. And some of the benefits of care coordination you can see on the screen here. So participation in the Behavioral Health Project and care transitions communities can improve the quality of life for patients with psychiatric, behavioral health, and substance use disorders. And you can see again some benefits of participation. And again, with working with the LSQIN, that we can provide access to education and best practice sessions, or best practice, via learning sessions, working to improve provider communication and the sharing of best practices with others. And I think we are done with the bulk of my presentation. Katina, if you could open up the phone lines for anyone that might want to ask any questions, and bring up the polling questions too. That'd be great.
Ladies and gentlemen, if you have any questions at this time, please press the number 1 key. Again, ladies and gentlemen, if you have any questions at this time, please press the number 1 key. And Mr. Lausch, I'm waiting for people to join the queue.
Very good. Thank you. Thank you. And just Katina, while we're doing that, let me just throw this out here too, that for Michigan social workers, let me forward this one here. Whoops, there we go. For Michigan social workers, in order to receive your CEs, please go to the website listed on the screen. You'll need to register if you're a first-time visitor, or you can enter your name and password. Then once on the site, fill out your information. It's going to ask for your social work license, because that's the way we have to monitor if you're a Michigan social worker. And it will take you to the evaluation site, and once you do the evaluation, you can download your certificate. The passcode is 123. Okay, just simply 123. If you experience any difficulties with getting your certificate, just please contact me at mlausch@mpro.org. And Gavin's going to put up in just a second where the recording can be accessed on our YouTube page.
And Mr. Lausch, no one is in queue at this present time.
Very good. Okay, thank you so much. Gavin's going to put up in the chat box the link for Michigan social workers to take the evaluation and get your certificate, the passcode being 123, and our YouTube URL to view this presentation. Thank you for joining me today and us for Integrated Behavioral Concepts. As a reminder, the recording of this webinar will be available on our Lake Superior Quinn YouTube page within the next week. Thank you for taking the evaluation, and for those of you seeking social work CEs, please contact me if you have any problems with that. And be sure to join us for our upcoming webinar on PHQ2 and PHQ9 on April 21st. More information will be available soon. Thank you, and have a great day. Nice to be with you today.
I would also like to say thank you, ladies and gentlemen, for joining. This completes your conference call. You all may disconnect, and I also hope you have a great day as well.